This is Frontline host Ryan Stanton. Before we get into today's episode, I wanted to invite all of our listeners to join me in Chicago this October for the 2026 ACEP Scientific Assembly. Alone, we each take care of our patients, but together, we can change the face of emergency medicine. Join me and thousands of your colleagues for ACEP 26. Register now at acep.org/ACEP26 and get free access to ACEP anytime. We'll see you in Chicago.
Welcome to So What, a Frontline podcast. Welcome back to So What, a Frontline podcast. I am honored to be here today with Dr. Spencer Greene, who is, for those of you who don't know, the expert on snake bites. I mean, he's got his running count all the time, but to more formally introduce him, he is the Director of Toxicology and an attending emergency physician at HCA Houston Healthcare in Kingwood. He's a clinical professor at the University of Houston College of Medicine, also having faculty appointments at the University of Texas, School of Nursing, and in the Department of Emergency Medicine at Wright State University. Comes to us all by way of Washington University in St. Louis, did his undergrad and master's, and then went off to Albany Medical College to get his MD, did his residency at Vandy, toxicology fellowship at Banner Good Samaritan. I mean, he's been everywhere, plus in the Air Force, and definitely thank you for your service. But along the way, you've become the snakebite guy.
Yeah, and I never would have expected that back 25 years ago when I was doing EMS in New York.
Oh, wait, I got to take that back for one second. How does a medic from New York end up becoming the snakebite guy?
It's actually really funny. I entered medical school knowing I would do emergency medicine because of my pre-hospital experience. And for all but about 6 hours of medical school, I waved the banner of emergency medicine. For 6 hours, I thought about anesthesiology because I liked the pharmacology and the procedures. And then I went down to Vanderbilt and I started doing EMS things. I was teaching in a paramedic program. I helped set up an elective for medical students as an intern. But then a few weeks into residency, I met our toxicologist, Donna Seeger, who at the time was the president of the American Academy of Clinical Toxicology. She was already like a rock star in tox. And I was just amazed by this large body of obscure knowledge that she had that most physicians never learn about. And I loved everything about tox, nothing in particular, but everything. And I thought to myself, wow, I can pronounce Latin words. I have a good memory. I can do tox. And I realized I wanted to do toxicology. And when I graduated from residency, I had a choice, or prior to graduation, I could fulfill that military obligation you referred to, or I could go do a fellowship. And it made more sense for my life, for my family, to just go ahead and just satisfy the military requirement. And I'm glad I did. I went off to Wright-Patterson Air Force Base and Wright State University, and I was teaching toxicology as a subject matter expert, not as an actual toxicologist. I essentially started a few weeks out ahead of the residents, but over the course of a few years, I got to learn a lot. And again, I loved everything about tox, but nothing in particular. I got deployed to Iraq with very short notice, like 6 days notice, and it actually messed up all the interviews I had scheduled for fellowship. And I had a lot of downtime. I can't talk about what I did until another 5 years and change, until June of 2031, thanks to my 25-year non-disclosure statement. But during my downtime, one day I found a saw-scaled viper, or parts of a saw-scaled viper, on our property. And I had an epiphany. I realized I really hated the cold weather that I left in Ohio. I really loved the hot weather in Iraq. And I really was fascinated by snakes and other venomous critters. And I ended up doing my fellowship in Phoenix because historically they are like the place to go for envenomations. And I graduated from there. I stayed in Arizona, moved to Texas for family reasons. And now, years later, I treat more bites than anybody else in the country. And if someone told me that would be my future, I would be like, you're insane. Why would I be in Texas treating snake bites? But that's what I do now.
That's hilarious because I kind of was on a similar path, but aborted it. I also started off as a paramedic firefighter. And when I started my education, I didn't want to be a doctor. I wanted to be a chemtrec first responder. And so I had actually gone to the University of Illinois at Chicago School of Public Health and got my MPH in environmental and occupational health and focused on environmental toxicology and really wanted to get a job going out when the trains crash. But alas, there wasn't openings. That I was on a wait list for that gig and ended up doing some consulting work in EMS and serving as an investigator for the fire administration, and said, this ain't for me, and went to medical school as an escape, and didn't really go back to tox, but still kind of have a soft spot in my heart for what happens when you put 30,000 gallons of trimethyl bad stuff onto hot asphalt in the middle of the summer's day. Because environmental tox is its own interesting challenge. But let's talk toxicology, and let's talk snake bites, because I've got Spencer Greene on my podcast. I mean, we got to talk snake bites. So it always happens that I think all of us have been in the emergency department and have had somebody come in who is, the most common is the spider bite, which we all know are not spider bites and are very rarely envenomations if they happen. And so we can leave those aside for right now. We all know how to handle those. But somebody comes in with a snake bite and they don't have the snake, right? And I live in North Carolina. I practice in Illinois, but I live in North Carolina. And so there's a fair chance it could be a copperhead. I mean, that they do exist. How do I make that determination if I don't have the snake there? How am I going to know if this is something that I got a problem or not? Because some of these don't show up instantly, right?
Signs and symptoms don't appear right away all the time, but they often do. The most important thing is that here in America, you absolutely do not need to see the species in order to treat correctly. Anyone who says otherwise doesn't understand snake envenomations. Here in the United States, there's really only two types of snake envenomations. You've got your pit vipers, which include coppers, cottonmouths, and rattlesnakes. And I should point out, cottonmouths and water moccasins are the same thing. It's amazing how many people don't get that. We always joke that if you're from the north, it's a cottonmouth. If you're from the south, it's a water moccasin. And if you're from this tiny little area in Louisiana where the family tree is a wreath, it's a stumptail. But it's all the same thing. But yeah, pit vipers are copperheads, cottonmouths, rattlesnakes. And then you have your coral snakes. And there's 3 coral snake species in the United States. And depending on which taxonomist you believe, there's between 20, 21, up to 30 different species of pit vipers. And ultimately, a pit viper envenomation is a clinical diagnosis, and a coral snake envenomation is a clinical diagnosis, so that you don't have to know the actual species. Most people who come in with pit viper envenomations will have signs early on. We'll see swelling. We may see bruising. Less commonly, especially at first, we might see hemorrhagic blebs. And there's something that I call a sheen. I don't know if there's a better way to describe it, but it's just something I'm so accustomed to seeing. The skin gets stretched to a point where it's almost shiny. And these indicate a pit viper envenomation. And people describe pain that's often compared to being hit with a hammer. They may have a puncture mark that's visible. They may not. Sometimes a fang mark is obscured by swelling. And oftentimes they don't have 2 fang marks because the maxillae for pit vipers are so mobile that you can be struck with a single fang. So we may see 2 puncture marks. We may see 1. We may not see any because it's obscured by swelling. But when we see this, we think it's a pit viper. The whole constellation of the discoloration, the swelling, the tenderness, the sheen, it's a pit viper envenomation. Coral snake envenomations, much less swelling, no bruising. Strangely, we see more erythema, and the pain is described differently. I don't know if you've been tased. I don't know what you do in your personal life, but a coral snake envenomation, it's more of a neuropathic pain and less of a blunt type pain. So that's what we see if they have symptoms initially. But this is the important thing. They may not have signs and symptoms early. So if there's concern for a snake bite, the most important thing to do in the absence of symptoms is to watch long enough. There's a lot of mistakes physicians make, and I can spend a few hours talking about all the physician mistakes I see. But there's really 2 that are most important. Not watching long enough and not pulling the trigger on antivenom early enough or at all.
So wait, let me get this straight, because I want to back you up here, because I'm just a schmuck working in the ER. For the most part, when they're going to come in, I'm going to look at 2 different types, right? I'm going to have this guy who's going to be swollen with maybe some hemorrhagic blebs, but probably not early. He's going to tell me it feels like he got hit by a hammer.
Right, and you'll see bruising, and you'll see like a sheen to the skin. Yeah,
that's my pit viper. That's my rattlesnake, my copperhead.
Right. And they account for 98% of the bites in the country. Realize coral snakes only account for 2%. If you're in a place with no coral snakes, it's a safe bet. It's not a coral snake envenomation.
But the coral snake will be more of a, got shocked kind of neuropathic pain, and it'll be red as heck.
It may be red. There'll be much less swelling. There will not be bruising. And there certainly won't be significant swelling.
But they could come in and look totally normal.
Right. So if someone comes in and they have no signs or symptoms, but there's a concern for snake bites, the important thing is to watch. All the major guidelines, including some that I've been lucky enough to author or co-author, say the same thing. In the absence of signs and symptoms, you watch for a minimum of 8 hours. And this is where physicians get it wrong. So many people discharge these patients after 2, 3, 4 hours, and then they come back later much more symptomatic. So if there's any concern for bites, but no objective findings and normal labs, because we should always check labs as well, you still watch for 8 hours. And if they have any signs or symptoms, you watch for a minimum of 12 to 24 hours. I tend to watch lower extremity bites longer because they can take longer before they fully manifest. So if there's a story that's worrisome for snake bite, a possibility of snake bite, and they have no signs or symptoms, you watch, because snake bites are dynamic. Just because someone has no symptoms at first doesn't mean 6, 7, 8 hours later, they won't be symptomatic. In fact, I had a guy, we used to treat him all the time in Tucson. He'd come in for either a diabetic related emergency or a snake bite because he kept snakes at home. So he'd come in with like, oh, what's his blood sugar? 106. Oh, he got bitten by a snake. Okay. But and then one time he didn't have any findings, but he was a reliable historian and we knew we got bitten by snakes all the time. So we watched them. The first set of labs were fine. We got a second set of labs and we got 2 phone calls simultaneously. The nurse called and said, hey, his hand's getting really swollen now. And the lab called and said, hey, his platelets went from 390 to 190. Now, 190 is not low, but a drop of 390 to 190, that is a significant drop. So you have to watch. Mistake number one that physicians make, they don't watch long enough.
Now, when we're saying we're going to watch, that applies to both coral and pit vipers?
Yes. Coral snakes, again, we're not looking for the same things, but we should see symptoms. We need to watch for a while. Some people talk about the delay of up to 15 or even 18 hours before the signs of coral snake envenomation come. And there are certainly some reports of that. But I see a fair amount of coral snakes. As I said before, coral snakes only account for about 10%, 2% of bites around the country. They're about 10% of what I see. And I see about 10 to 15% of all Texas coral snake bites in the country. They usually have symptoms right away, certainly within a few hours. So you're watching for the development of the pain, the paresthesia. Again, fewer objective findings than we see with pit vipers. And again, if you're not in a place with coral snakes, none of this is relevant. But pit vipers are found in almost every state, so they're much more important.
Where do we worry about coral snakes?
So there's 3 species of coral snakes. The Sonoran coral snake is found in and around Arizona. The Texas coral snake is found primarily in Texas, but in the southeast corner of Oklahoma, the southwest corner of Arkansas, and western Louisiana. And then the eastern or harlequin coral snake is found in Florida, a little bit Georgia, Alabama, and then to Mississippi.
It doesn't get up to me in North Carolina, right?
They can go South Carolina and to a little bit North Carolina. So you do see them, but primarily in Florida. So I was thinking east to west rather than north-south. But yeah, they can get in the Carolinas. They're uncommon, but you can see them. So unless you're in one of the states I just mentioned, it's not an issue. It's not something to worry about. I should also point out that as you go from west to east, they get more dangerous. Historically, bites from Sonoran coral snakes don't require really any workup. I've had friends bitten by them, they go, ow, it hurts. Texas, we see a lot of pain and paresthesia. We only see systemic toxicity in about 3.6% of cases, meaning we see something more than pain and paresthesia in 3.6%. And I published a paper last year showing there was actually geographic variation among Texas coral snakes. Like in Northeast Texas, it's much worse than South Texas, for example. And then we tend to see a little more often objective findings when it comes to the Eastern coral snake. There has never, ever, in the history of everness, been a documented fatality from the Sonoran coral snake or the Texas coral snake. And deaths from the Eastern coral snake are infrequent. The last one was in 2006. It was a drunk guy who got bitten at the same time as his friend got bitten. His friend sought medical attention. He didn't, and he was dead next morning.
Yikes. So first mistake is I don't watch long enough. And you're saying I got to watch for a minimum of 8 hours, and it could go longer than that if there's any question. But the second mistake, if I heard you correctly, is I don't grab for the antidote soon enough.
Right. So the other mistake with snakebites is not giving antivenom aggressive. There's this idea among a lot of clinicians, emergency physicians and others, that antivenom is the last line of defense. Antivenom is your first line of defense. Antivenom is how you treat an envenomation. And in general, we should be using antivenom for all but the most clinically insignificant bites. If someone has pain and swelling and tenderness that's extending, if it's progressing to the point where it crosses even approaches a single major joint, whether that's a wrist or an ankle, we should be giving antivenom. If they're having systemic toxicity, such as hypotension or recurrent vomiting or diarrhea, they should be getting antivenom. If they have clinically significant or potentially clinically significant laboratory abnormalities, thrombocytopenia, hypofibrinogenemia, those are the most important ones, we should be giving antivenom. So many people think that you need a good excuse to give antivenom. What you need is a good excuse to not give it, because the reflex should be to do it. Almost all envenomations should be getting it. Only the really insignificant ones. It's kind of like a house fire. You were a firefighter. I was a firefighter. If your house is on fire, say the living room's on fire, you don't wait for it to spread to the dining room and the kitchen and say, oh, I should probably use water. When there's a fire, you extinguish it. And that's actually a good analogy, because the sooner we treat, the less damage and ultimately the less expensive than if we wait for it to get really bad. And so many people take this two-joint approach, which sickens me. And they say, oh, well, I'm not going to give antivenom until the swelling and tenderness get to two joints, like the elbow or the knee. That's crazy. You give it early. It's more effective. It's better for the patient. They get better faster. It's better for everyone.
Yeah, well, it's funny because in North Carolina, so I lived the entirety of my life way north of the Mason-Dixon line, having grown up around the Chicago area, and then went up into Minnesota for residency, and then kind of came down into near central Illinois and then Ohio in the Cleveland area before finally 10 years ago moving to North Carolina. And so we weren't really worried about copperheads or bites much in the north. I mean, yes, I understand they occur, but I honestly had never seen them. And when we moved to North Carolina, we definitely experienced it. We also experienced it with our neighbors even, the kind of mythos about this. And you're right, there's like this, well, I was bitten by an adult copperhead. I know it was a copperhead, and I got bitten by an adult copperhead. I'm not even going to go in because it's only the juveniles that'll envenomate me with all of their venom, and it's not going to matter. And it's swelling a little bit and it's bruised a little bit. But that darn antidote is so expensive, and I really don't need it. Honestly, these are the things that you hear. We hear all the time that you don't got to worry about the adult copperhead because it'll be a dry bite, or it'll only be a little venom and you won't be that sick. But the juveniles you got to look out for because they can't control themselves. All right, apparently they're 18-year-old boys.
Yeah, so you just brought up so many things. I'm trying to seriously write down all the things I want to hit on. You brought up my favorite myth, the most pervasive myth. The biggest myth when it comes to snake bites is that juveniles are more dangerous than adults. That, of course, is nonsense. And it's two myths in one. First of all, the myth is that juveniles are more dangerous because they release all their venom in a bite, whereas adults can meter it. We know that juveniles are born with the ability to regulate how much venom they deliver, just as well as adults can. So that is just nonsensical. But even if they could, which they can't, if they couldn't control their venom, but they can, it's simple math. Let's say a juvenile delivers 10 milligrams of venom, 100% of its venom, and an adult only delivers 25% of its 80 milligrams. On average, an adult is delivering more venom. And on average, an adult bite is way worse than a juvenile bite. Now, I say everything's on average because every bite is unique. You can have a severe bite from a juvenile. You can have a mild bite from an adult. And that's true among species, too. You can have a severe copperhead bite. You can have a mild rattlesnake bite. On average, rattlesnake bites are worse than copperheads, but the overlap is great. Every bite's unique. Every patient has to be assessed as an individual. But yeah, there's this myth that juveniles are more dangerous, and that's generally not true. And you brought up the concept of dry bite. This, too, is something that's so frustrating. I think you're a member of National Snakebite Support. And in the summer, we'll get this every day. Oh, yeah, I got bit by a copperhead. I have swelling and bruising, but my labs are fine, so my doctor told me I have a dry bite. Who are these doctors? These doctors are idiots. A dry bite means you have no venom effects whatsoever, nothing. It means you have no symptoms. It means you had something that felt like a paper cut. It hurt for a second, and then you were fine. A dry bite means you have no evidence of envenomation. If you have swelling and bruising, where the hell do you think that came from? It's a venom effect. Maybe it doesn't warrant treatment. Maybe it does. Like I said, it usually does. But if you have swelling and bruising, that's an envenomation. Anyone who calls it a dry bite should give up his or her license because that's nonsensical. So that's a huge pet peeve of mine. Dry bites are infrequent. Fewer than 10% of the bites that we see in the emergency department are dry bites. Fewer than 10%. Does it happen? Of course. But most of the time it's either a misdiagnosis or you don't watch them long enough to see the venom effects. If you watch someone for an hour and say, oh, they're asymptomatic after an hour, I'm going to send them home, they may not have manifest yet. And so many times they have symptoms later on. I've been involved with a bunch of cases as an expert witness for both prosecution and the defense. Not at the same time, that would be confusing. But one of the worst cases ever was someone who was bitten by a Western diamondback rattlesnake, came in 90 minutes after the bites. No, pardon me. He came in 30 minutes after the bites, already had swelling, already had tenderness, so clearly was envenomed. They watched him for 90 minutes, checked no labs, sent him home, and a few hours later he felt really bad, so he went to another hospital. And at this point, his platelets, which presumably were fine before the bite because he's a young, healthy guy, his platelets were 8. His fibrinogen was unmeasurably low. His PT was unmeasurably high. And within 24 hours, his leg was covered in hemorrhagic blebs. He spent 8 days in the ICU. That was a huge payday for him. And the cool thing is he recovered fully. But the doctor was successfully sued because he didn't watch him long enough. He didn't do the right thing. And the hospital was actually hit with an EMTALA violation because they didn't do the necessary screening exam to exclude a life-threatening condition. They didn't check labs on a freaking rattlesnake bite. You can't call it a dry bite after an hour. You can't call it a dry bite if they have signs and symptoms. A dry bite means they have nothing. And if they have anything more than a little swelling, they have an envenomation that's warranting treatment. So going back to not getting treated, there's so many reasons I hear clinicians say they're not going to treat. Some people exaggerate the risks of antivenom. With the antivenom we use today, the safety profile is much better than what we used before 2000. We have Crofab and Anavev. They both have good safety profiles. I think the data continue to emerge that Crofab is safer, especially in areas where alpha-gal syndrome is high. But they're both good products. They're both safe products. Some people minimize the effectiveness of antivenom and say, oh, well, it doesn't make a difference. It does make a difference. We have plenty of evidence. In fact, I was one of the authors of the only randomized clinical trial ever done on copperheads showing that even mild bites, and certainly moderate bites, we didn't test severe because it's sort of intuitive. Even mild bites, and especially moderate bites, they do better when they get Crofab early on, as opposed to those who didn't get treated. They get faster recovery, and they require fewer doses of pain medicine and a shorter course of pain medicine. We know that antivenom works, and we know it's safe. And then some people just minimize the significance of a bite. They say, oh, well, they'll be fine. And you know what? Most people will eventually be fine. I said 2 important things there. Most will be fine. And eventually, people who go untreated or undertreated might take much longer to get better. It may take months for full recovery. And depending on the study, up to 20 to 30% of people won't recover fully. So now you're going untreated, and you know what? A year later, you don't have full function. And that can be life-altering for some people. People always talk about the financial implications of getting antivenom because it's so expensive. But what they often don't talk about are the financial implications of not getting treated. If they can't work, if they can't do their livelihood, that is arguably a longer financial complication. So I hear all these excuses. The bottom line is most envenomations should be getting antivenom. And if you're not giving most of your patients with snake envenomations antivenom, then you're not doing it right.
And here's the part that I think we really have to, because I remember it was a couple of years ago that you and I got into a discussion on the same side on folks online talking about the costs of the treatment. To what degree do we tell our patients about the costs when we're listing the risks, benefits, and alternatives for them? Because, obviously in this day and age, we want to involve our patients in decision making. And I've always been a kind of a purist and say, I don't love including costs in that because I don't know necessarily what their insurance coverage is. And I really, to my reading of EMTALA, I'm not supposed to, right? I'm supposed to treat everybody the same. The standard of care doesn't change whether you're a prince, you're a pauper, or anything else. But some people have argued, well, no, you gotta tell them, it could bankrupt them, blah, 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 blah. But I think the important point here that I don't think people are giving enough attention to, and I fully agree with you, is what you're telling me here is that there is actual risks that if I don't treat this person, and I'm not talking about the med mal implications, I'm talking strictly about the implications to the patient, right? That this guy gets bit on the hand, maybe it's going a little bit past his wrist. It's not the worst bite anybody's ever seen. His labs, he's getting a little thrombocytopenic, but nothing horrid. One of these kind of like mild cases that my neighbors seem to talk about, right? That some of these people are calling a dry bite. I get it. It's a misnomer. It's not a dry bite. But you're saying that if they don't get treated, that they could lose function of the hand, or they could have ongoing, permanent even sequela of this mild to moderate bite.
Exactly. And like I said, most people will recover. In our randomized clinical trial, everybody did eventually recover. In another study out of North Texas, everyone recovered. But in other studies, including one out of Kentucky, over 20% of people had permanent disability. They stopped checking it a year. And at 1 year, some people, up to 20%, had loss of function. And then I realized that the plural of anecdote isn't evidence. But there was a woman I saw in outpatient clinic months after the bite for something different, another tox related thing. She was a triathlete, and she went to one of the hospitals in Houston that's notorious for not being good when it comes to bites. And she had swelling that progressed from her foot all the way to her knee, and they never treated with antivenom. She was a triathlete, and now when she stands for long periods, she gets pain and swelling in her foot. She can't stand for long periods. She certainly can't run for fun, and she absolutely can't run competitively. That was her thing. That was her gig. And they ruined her life by not giving her antivenom for whatever crazy reason they used to justify not treating her. There are a lot of people who have long-term effects. And yeah, antivenom is expensive, but you know what? At least with the hospital, you can work on a payment plan. You have one shot at a first impression, if you will. For snake venom, you have to treat it now, or you can't treat it a year later. It's too late. You got to do it early. With money, at least you have time to figure it all out.
Is there anything that can be done? So if I've got the patient who shows up and is like, Doc, I'm here because my hand hurt. It's 3 o'clock in the morning and my hand has hurt for 6 months. And I got bit by a copperhead 6 months ago and I didn't come in for treatment. My hand is still kind of a little swollen. It kind of looks like a little lymphedema. And to be honest with you, I mean, it just hurts when I flex. Is there anything that I can do for this person other than arthritis type treatment?
As an emergency physician, not really. Some people require physical therapy. Some people can develop complex regional pain syndrome, and those are obviously really difficult patients to treat. I make sure physical and occupational therapy are involved with the care of all my bites in the hospital, and then if they need an outpatient, I usually arrange some sort of treatment plan as an outpatient so they have good range of motion. What I see a lot, especially in kids, they'll have improper elevation when they go home, and then they develop a contracture because they had their leg bent at 90 degrees. Whereas I make sure everyone's elevated to about 60 degrees, but completely straight, like the leg's 180 degrees. So you don't get contractions. I have them do range of motion, but when they're resting, it's straight. If you rest it with a 90-degree angle, it's going to stay that way. So they need weeks of physical therapy after. As an ER doc, you can control their pain, but the big thing is you got to plug them in, maybe to wound care, depending on what the local findings look like, maybe pain management, physical therapy. But obviously, preventing this is a whole lot better than trying to treat it later on.
So let me go back for a minute, though. So, you've said you gave us that case where somebody didn't get labs. Okay, I'm a northern schmuck. What labs?
So the labs I care about, honestly, CBC, fibrinogen, and to a lesser extent, PT. We often refer to the prothrombin time as a poor man's fibrinogen. Labs I have never intentionally ordered on the snakebite. Labs I couldn't care less about. D-dimer, PTT, fibrin split products. Some of them may have some relevance in other countries, but in the United States, we follow the platelet count, the hemoglobin, the fibrinogen. And then if they have comorbid conditions, I might check a BNP. If I'm worried about rhabdo, either because of a lot of tissue injury or because certain snakes are known to be myotoxic, I do get a CK. I'll be honest, I can't recall a time it ever has changed anything, but they ask about it in the North American Snake Registry, so I get a CK. And then if they have underlying medical conditions and symptoms related to them, like if they come up with chest pain, I'll check a trope, for example. But the labs I care about, honestly, CBC, fibrinogen.
Now, this is your podcast. Guy comes in with a bite. I grab my labs right away. He doesn't have a whole lot of convincing symptoms. He's one of these guys that I'm going to watch. How often am I repeating those labs?
I get them on arrival, and if they have no local findings, nothing that's worrisome, I'll get them again in about 6 hours. And then if after 8 hours they have no signs or symptoms, they go home, and I think we can safely call them a dry bite. But it's really important to be honest. Do they have no signs or symptoms, or do they have like minimal ones? Because the minimal ones require further monitoring. If they have no signs or symptoms, and like I said, we do see dry bites, fewer than 10% of the time, but we do see them. I had a guy who came in, he was holding the copperhead that bit him, so I knew what bit him. There was no question about it. But he got just a graze and he had a little scratch. He had no swelling, no tenderness. I watched him for 8 hours. He had no development of anything. His labs were fine. He had nothing. I can safely say he had a dry bite because we watched him long enough. We examined him carefully enough. We reassessed him frequently enough to know that he had nothing.
Let's take that guy for a second, because I think it's going to be a great example for us. So we watch him for 8 hours. There's nothing. We do nothing. Now, let's assume, for the sake of argument, that the bite occurs on the web space between the index finger and the thumb. Gives us a nice easy mark, right? And I just have some swelling that doesn't actually get all the way to the wrist. And maybe, it's a little, he's definitely got some pain, but he can move. And I've watched him for 8 hours. His CBC is fine. His platelets aren't super low or anything like that. Platelets are 200 and level on a repeat 6 hours later. Do I still give him antivenom or no?
In the absence of systemic symptoms, in the absence of hematological lab abnormalities, and there's no progression, I would not give him antivenom. I would keep it elevated to help minimize the swelling, but I would feel comfortable holding off on antivenom. But you said something before I didn't get a chance to get back to. We were talking about having the discussion about the costs. We don't have discussions when people come in with accidents. We do the big trauma workup, which we know is often very low yield. When someone comes in septic, we don't talk about the price of antibiotics. Now, I realize antivenom is much more expensive than most antibiotics.
Yeah, but it's not more expensive than most trauma activations. Let's be honest.
Exactly. And we do $1 million workup for what's often a $7 problem. And the $1 million workup is actually not much of an exaggeration. But for a snake bite that clearly needs it, I do not have the discussion. They came in because they have symptoms. This is how we treat the bite. Like, for the really mild ones, that's when I do shared decision making. And I talk about the financial implications. I talk about the financial implications of going untreated. And then I reassure them it doesn't affect me at all. First of all, I don't get paid by the hospital for snake bites at all. I bill the patients for seeing them for a snake bite and admitting them to my service. But whether I give them anti or not, it's no financial implications to me. I tell them what to expect if they get bitten, if they go untreated, what to expect if they get treated. I tell them what I would do if this was a child I liked. For the really mild ones, we do shared decision making. But for the more clinically significant ones, I don't, because in other things in medicine, we're more paternalistic. They come in, when I have a kid with a laceration, I don't discuss with the family how I'm going to do the repair. I'm going to do the repair the way I think it works best. And I realize we're talking about different finances, but in general, I don't have it unless it's really on the fence. And then every once in a while, I have someone who really wants antivenom, and it's just such an insignificant thing that I wouldn't give it to them. I tell them why I wouldn't, and I reassure them, like, this is what I do. I'm going to watch you a lot, and I'm going to give it the second you need it, but I don't want to give it to you before you need it, because even though drugs have great safety profiles, nothing is 100% safe, and it ain't free either. So on the rare occasion when someone wants it, they don't need it, I explain why I'm not doing it. And I think I have enough credibility at this point where they listen to me.
Now, okay, but going back to our patient we know is bit by a copperhead, if it crosses the joint line, right, the guy's bit on the thumb and it goes past the wrist, but there's no laboratory abnormalities, nothing that's looking systemic, do we give antivenom then?
And the thing is, most of the time the labs will be fine. It's rare to see lab abnormalities, not never, but rare, where we should base most of our treatment decisions on the local findings. Yeah, if they have a bite to the hand and it's the swelling and tenderness across the wrist, I treat that. And we're elevating, we're treating, we're admitting them, unless you have like an OBS unit in the ED, but that's more of a local thing. Yeah, that warrants treatment. We don't make decisions based on labs and systemic. What we see with pit viper bites, we see local injury in over 95% of envenomations. And we see nothing but local findings in over 75%. So the absence of lab abnormalities, the absence of systemic toxicity doesn't mean it's not an envenomation worth treating. It just means they don't have lab abnormalities or systemic toxicity. Most of these envenomations should be getting treated. And if they have local findings that are progressive, we treat that, irrespective of what else is going on. That in itself is a reason to treat. And I think that's where most physicians fail. They say, oh, well, their labs are fine, I'm not going to treat. You treat for the swelling. You treat for the thing that's going to have the most long-term implications.
Dave, that sounded important. Play that back.
And I think that's where most physicians fail. They say, oh, well, their labs are fine, I'm not going to treat. You treat for the swelling. You treat for the thing that's going to have the most long-term implications.
Okay, let me cover a couple of other things that I know. One of them I know is going to make your head explode, but what about doing the fasciotomies, right? I got a lot of swelling. This guy got bit in the calf. It's swelling up big. We got to cut that open, right?
If you Google the incidence of compartment syndrome in snake bites, some of the nonsense you'll see on the internet is that up to 50% of snake envenomations result in compartment syndrome. Now, I've treated over 2,000 bites. That means, in theory, I should have seen, 300 compartment syndromes, and I've never had a patient with a compartment syndrome. And I watch these people for weeks after the bite, so Compartment syndrome, really important to know. First of all, true compartment syndrome is exceptionally rare. It's probably closer to 1 in every 10 to 20,000 bites. So most physicians will never see an actual compartment syndrome in their careers. But equally importantly, even if there's a true compartment syndrome, we treat it differently from compartment syndromes that are due to trauma. When you have a compartment syndrome due to trauma, it's the increased compartmental pressure that's causing the damage. That's the major problem. With snake envenomation, elevated compartment pressures are a sign of a bad envenomation, but they're not the cause of it. The analogy I love to use is hyperkalemia in the setting of digoxin toxicity. In digoxin toxicity, if you're hyperkalemic, that means you have a bad prognosis. And if you don't treat the digoxin toxicity, you're going to die. Like anyone with a potassium over 5.5 from acute dig toxicity, if you treat the hyperkalemia but not the dig toxicity, you still die. But if you treat the dig toxicity, the hyperkalemia resolves. It's the same thing with snake envenomation. If you have confirmed elevated compartment pressure and you open up the compartments but don't treat the envenomation itself, the muscle still dies. But if you treat with antivenom and you neutralize the venom effects, the compartment pressures normalize. The only time a compartment should be opened up, the only time a fasciitis should be performed is if you have confirmed compartment syndrome with hard signs and they fail to respond to appropriate doses of antivenom and appropriate elevation. And that is so infrequent that I think it's safe to say we should not be doing surgical intervention on snakebite patients. The only corollary to that is, well, I should say acutely. Every once in a while, every year, someone's going to lose a finger to a pit viper bite. Usually a rattlesnake, but it could be a cottonmouth or a copperid. If they have full thickness necrosis that doesn't recover after a few weeks, they may lose a finger or part of a finger. But even then, that's not acute. I'll say it again. Acutely, these are not surgical conditions. These are medical conditions. And these are patients best managed by medical toxicologists on a medicine service or whatever, not by surgeons. These are not traumas. And in a lot of places where surgeons are involved in these fights, we need to change the thinking.
Okay. Another quick question for you. We are in this era of don't give opioids, don't give opioids, don't give opioids. And we're talking about envenomations, which can affect your bleed times and certainly can affect your platelet counts. Do you stay away from NSAIDs?
Some papers came out a few years ago suggesting that NSAIDs were safe in copper envenomations for which there's no evidence of hematologic toxicity. I will, on rare occasion, give NSAIDs once I have several sets of normal labs. But acutely, before I have at least 2 sets of normal labs, I'm avoiding NSAIDs, whether they're parenteral like ketorolac or oral. I use a multimodal approach to pain control for snake envenomation. I give them opiates. I have no problem giving opiates. This is one of those situations where it's appropriate to give opioids. I don't like morphine. Morphine is more histaminergic than many other opioids, so I either use fentanyl or Dilaudid. Dilaudid is my favorite, both because of its kinetics, but also because I tell people A, B, C, D, E for snakebite, airway breathing circulation, Dilaudid elevation. And if I used anything else except for maybe Demerol, that mnemonic wouldn't work. Imagine if I use morphine to be ABCME. That makes no sense. I almost always use transdermal lidocaine. I find that helps a lot with the pain. It's the only medication patch that can be trimmed. You can't trim a clonine patch or a nicotine patch or whatever, fentanyl, but you can trim a lidocaine patch and put it right on the bite side. And I find that helps a lot. Elevation itself helps a lot with the pain. On occasion, I use gabapentin. On rare occasion, I'll use subdissociative ketamine. And on occasion, I even use intravenous lidocaine. Intravenous, not local. And I find using this multimodal approach, and of course acetaminophen, which I'm not worried about affecting the platelets, I get good pain control. Yeah, I built order sets for all the snakebite patients I admit. They get Tylenol for mild pain, 1 to 3. They get oxycodone. This way I'm not doubling down on the acetaminophen. So they get oxycodone for moderate pain, and they get Dilaudid for severe pain. And they get a lidocaine patch as soon as they come in. They get changed every 8 to 12 hours. And I find it works really well.
Now, the other question that I have is if I've got this snakebite coming in, is it poison control that I call? I'm talking about, the guy who doesn't, like I said, I'm working in Springfield, Illinois right now. There are, in theory, pit vipers that could affect in Central Illinois, but they certainly were, we're not a hospital experienced in the frequent thing. So do I start at poison control or is there
We're working on the updated version of the unified treatment algorithm, which I think is the Bible when it comes to managing snake bites. The first one came out in 2011. I wasn't involved in that. That was pretty early in my career. I'm fortunate to be one of the authors working on the new version, which will hopefully be out later this year. We're refining it. We say call poison control or an expert. It depends on where you are. Now, poison control is a great resource, but I have found that the quality of advice when it comes to snake bites specifically varies state to state when it comes to poison control. I don't want to name any for a recorded sort of presentation, but some states are a lot better. And I will say, like, Arizona is great. And I think Alabama is great. I'll say that. There are some states that are really bad. I'm reluctant to recommend calling them, but you got to call someone who knows more about bites than you. At my hospital, we obviously don't call poison control because people call me 24/7. I'm available. I've got my team.
Well, and how do we get a hold of you then?
I'll give anyone who asks my phone number, and I get calls all the time. I should prefer text. That way, if I'm sleeping, I can text quietly without waking anybody up.
But is it worth like just calling HCA Houston Healthcare Kingwood?
Or our transfer center. That's what some people do. They'll call our transfer center, and then the transfer center will call me. But I'm not the only expert in the country. I'm an expert. I'm around here, but there are probably people who are closer to you. Obviously, the folks in Arizona are really good. The folks in Denver have a lot of experience with this. And there's others I don't want to mention. Chuck Gerardo in North Carolina is the multiverses expert on copperhead bites. So there are people to call, but you got to call someone who knows more than you.
Now, the unified guidelines, the ones that are currently published, are they still a decent set to utilize?
The big things that have changed since the first guidelines were published. We have a second antivenom, and there are differences between the two products in terms of safety and effectiveness, and specifically what they're treating. One's better for local findings, one's better for hematologic recurrence. So that's a big thing. And then when the initial ones were published, we didn't have as much data on copperhead bites that we have now. Like I said, I was one of the authors of the randomized clinical trial for CroFab for copperheads. That was published in 2017 or 2016. I've lost track of time now. That was published after the unified treatment algorithm. So now we have good objective evidence for good objective data on copperhead bites. And of course, we have more data looking at the safety and effectiveness of the two different antivenoms.
Let me back up and get to that, because you'd mentioned alpha-gal before. So what is the difference between the two antivenoms? To be honest, I don't know that I'm going to have much of a choice, right? It's probably going to be what my hospital stocks, if they stock it. And we'll talk about that in just one second. But what are the differences, and where does alpha-gal come in?
Okay, so for people listening who aren't familiar, alpha-gal syndrome is an emerging, I don't want to say threat, but we call it like the red meat allergy. Basically, you get bitten by a tick, you get sensitized, so you develop IgE antibodies to this carbohydrate that's found on non-primate mammalian proteins. And it can vary in severity from mild, where you can eat some meat products, but you can't eat the really fatty ones, to severe, where even eating dairy products like butter can cause life-threatening anaphylaxis, and it usually manifests several hours later. It's not as immediate as most food allergies. It usually takes a few hours, could be up to 10 hours. And because antivenoms are mammalian-derived, CroFab comes from sheep and antivenom comes from horses, they are non-primate mammalian proteins with this carbohydrate on them. And you can have an adverse reaction. I don't know the exact numbers. There's a few studies out there, including one that I co-authored, showing that we see more adverse reactions, including more anaphylaxis, which is really the one that matters, with antivenom as opposed to CroFab. I'm going to try to pull up Ari Phillips' paper because it was published a few months ago. The difference is actually pretty significant. Yeah, so in his study, they found adverse reactions without presumed anaphylaxis occurred in 21.6% of patients who got Anavet and 4.1% of patients who got CroFab. So that's a pretty significantly significant difference. And then for anaphylaxis, it was 1.8% for CroFab, and it was 16.2% for Anavet. One of the arguments we hear all the time about the different products and allergies, like, well, if they just have itchiness, who cares? And yeah, most adverse reactions aren't clinically significant, but anaphylaxis is clinically significant. And we're looking at 1.8 versus 16%. That's a huge difference. But like you said, a lot of times you only have the one product. So that's the one you're going to use. And the thing we always emphasize is that if an envenomation needs antivenom, you give it. We can always prevent allergy. We can always treat allergy. That's what epinephrine's for.
So I was going to say, I mean, I can just picture the nightmare scenario, and because I do these podcasts, and I always worry that I'm calling down the call gods, right? The minute I've discussed this, I'm going to be dealing with a copperhead bite on my shift later tonight, and of course, it's going to be somebody with confirmed anaphylactic alpha gal, and here I am going to be starting my epinephrine drip right alongside my crofab.
Yeah. Sometimes we got to do that, and that's okay. But yeah, if you have the choice, realize that we see fewer severe adverse reactions to Crofab than Anaviv when it comes to alpha gal. Now, for most of the country, this is a non-issue, although the geographic range of alpha gal is getting worse. It was just a fatality up in New England not too long ago attributed to alpha gal. But there's a lot of places in the country that have never seen this or heard of it.
To be honest with you, though, I was working very recently because I do travel work for Vituity, and we had a one of our sheriff's deputies who was our security who confirmed alpha gal in the middle of rural Indiana, and he absolutely had it. Like there's no question whatsoever, and definitely got an anaphylactic reaction after having a fatty brisket, and we ended up having to epi in the whole 9 yards. So I think in limited amounts, it is everywhere. But I think it's a lot like, it's a lot like pit vipers. Technically, they are everywhere in the United States, but there's some places that are a whole lot more common than others. And I think that's true of alpha gal at this point.
We don't really see pit vipers anymore in Maine, obviously Alaska, but that's not CONUS. And obviously Hawaii, we don't have pit vipers. Yeah, it's funny. I eat like I have alpha gal syndrome, and I have a colleague who does have alpha gal syndrome. So we often dine together because we have the same foods. Because he has to by choice, but I just don't eat mammals because we have all these foster animals. Whereas I think chicken and fish, they're on their own, man.
All right. So the other thing I just wanted to touch on briefly, because I find it fascinating having followed you on social media and having been part of looking at things on social media for snake bites, there is a whole subculture and community of folks who care for differing exotic snakes. So, as I understand it, if I get somebody who comes in and says, "Hey, listen, I keep cobras, I need antivenom, I got bit by cobra," and that it's usually the local zoo or those types of folks who are going to potentially have the supplies for those things. We would call those folks, and we can count on the people who do have these exotic snakes will generally know what they have, and will we kind of got to take them at their word if they're telling us that this is what's what.
Yeah, so I'm okay with people having non-native venomous snakes in their collections. I think they should be obligated to maintain their own stock of antivenom. In fact, I work with a bunch of people who help keepers obtain it, filling out the FDA forms and all that stuff. I think with your rights come certain responsibilities, and you should have your own because it's not the zoo's responsibility to treat you. Zoos keep antivenom for their staff. And sometimes zoos don't have the right antivenom for you, especially if you have an obscure snake. I work with the Houston Zoo, and they've always been really generous, and we have a little more than a dozen different varieties, but we don't have the antivenoms for everything. The more responsible keepers, and there's a million of them in Texas, I know a lot of them, the more responsible ones, they have their own antivenom, so they bring it with them, and that's what we use. If someone gets bitten by a non-native and they don't have antivenom, maybe the zoo will give it to them, to us to use. Maybe they won't. Maybe they can't because they don't have it. And then we have to call around. There's a great resource down in Florida, Venom One, and I had to use them back in September 2018. And they flew something to me on United Flight 330, I think it was. Got there like at 10:30 at night. That's the one time I've had to get something from outside Houston. But my fear is like someone's going to get bit by a boom slang or an Australian snake. And at least with an Australian snake, where I'm worried primarily about neurotoxicity, I can just intubate them and just ignore the fact that they're paralyzed now because at least I'm breathing for them. But if someone gets bit by a boom slang, there's nothing I can do about it. I can watch them bleed to death because blood products just aren't going to cut it. And I don't have access to boom slang antivenom. So, yeah, if someone has a bite, you have to take their word for it. Again, they might be lying, they might be wrong. I don't know why they would, unless they were trying to hurt themselves or they're just confused. But you got to take their word for it. Hopefully they have their own, but if not, you got to call around. There's a great resource called the Antivenom Index that's maintained by the AZA. It used to be housed in Arizona. To be honest, I don't even remember where it's housed now. New Mexico, maybe Nebraska. I'm not even sure because I haven't had to use it because I work directly with the zoo. And they can help locate this stuff. Sometimes it's a city over, sometimes it's a state over. We've had people call state police and transport things to the state line and then hand them off to another state police officer and then bring it to the hospital.
And that brings up the point, though, that I was going to try and get at, too, is I don't know if every hospital I work at, especially in the Midwest, has antivenom. Probably where I'm at right now, which is a level 1 trauma center, they might. But I can certainly know that some of the rural hospitals I've worked at in the Midwest especially don't have this. Is there a resource? Will poison control have those folks for us? I mean, let's say that we've got the very clear bite, right? We know that it's a pit viper. It has all signs. We're going to leave aside all the controversies that we've talked about, all the errors that we've talked about. Everyone agrees this guy needs to be treated. They've got hemorrhagic plebs. They got systematic toxicity, blah, blah, blah. If I don't have Crofab or Antivep at my hospital, how the heck do I get it quick?
You can call poison control. Usually your pharmacy will know whom to call. They know. I mean, ideally, if you're in a place that has snakes, you identify the places that have antivenom. The bigger hospitals are more likely to have it, but every once in a while you might find a place that just has it for whatever reason. Like my hospital's not the biggest in Houston, but we have the busiest snakebite service by far, and we have a lot of antivenom. I don't know if we have the most. We certainly use it the most. But yeah, that's just something that you should plan ahead for. But your pharmacy should be able to help. Poison control should be able to help. There should be a way to. And then, of course, I should make a plug for our group, National Snakebite Support on Facebook. We can help identify the closest place that can definitely treat definitively.
And National Snakebite Support, guys, by the way, if you haven't been on there on Facebook, is amazing. It's an interesting Facebook page because they very rigorously moderate it so that only moderators and administrators are answering any of these posts. As a matter of fact, I think the first thing that goes up on all of them is do not respond to this, even if you think you do know something about this. But it's an interesting one to watch as people have various envenomations and as you and your colleagues try to prevent us ER docs occasionally from making some of these errors that we've talked about. But if I'm going to summarize what I've learned here is that, number one, I need to watch these folks and really watch them for up to at least 8 hours if they're showing no symptoms before I call anything a dry bite. And number two, give the antidote early, give the antidote often if there's really any signs, because these folks can have honestly debilitating injuries afterwards if we fail to do so. And yes, those might be local, but if you've lost the use of your hand, you've lost the use of your hand, and that's a big, hairy deal, or lost the ability to run or do other things. So I really appreciate that, because this is not a topic that I think a lot of us are that comfortable with. And as you point out, those who purport to be comfortable with it often are working off of some bad information. So is there a way, not pager, not whatever, but if somebody wants to email you a question, do you have an email that you don't mind giving out that somebody could just get in touch with you? Or
it's really simple. Spencer, my first name, SPENCER .Greene, GREENE at hcahealthcare.com.
All right. And as always, you can get a hold of me at howie.mell@gmail.com. I'm old enough to have had one of the original Gmails and still got my name. So, certainly I appreciate all your expertise. I'll give you the final say. Is there anything you want to close with? Any final parting thoughts for us here in the non-tox world?
Spay and neuter your pets. I feel like I'm going to take the mantle from Bob Barker. So spay and neuter your pets. I was actually thinking about that earlier today. And of course, we have a million pets. But join National Snakebite Sports. Don't be an idiot. Don't let hubris get in the way of providing good patient care.
I really appreciate that. And thank you for coming on. And thank you all for listening. And remember, whether it's Schadenfreude or saving lives, we've got the best job in the world. Thank you for listening, everybody. You have been listening to So What? I am your host, Howie Mell. My editor extraordinaire is Dave Polk, and we both thank you for all you do and all the times you do it. Thanks for listening. This has been a Frontline Podcast.